Okay, hello everyone. We will continue at the neuroophthalmology lecture again, which is the second part. Okay, so we are still under the neuromotility. As you all know, anatomically we have 4 recti muscles, which is the superior rectus, lateral rectus, medial rectus, and inferior rectus. Okay. And we also have the superior oblique and also the inferior oblique. Okay, the rest are probably easy, going up, down, temporal and medial, but the oblique muscles is probably a little bit tricky. Okay, so the function of the superior oblique is going downward, and also for the intorsion. Okay, it's basically looking this eye is looking at the nose, down and in. Okay, it's always down and in, looking at the nose. All right. Okay, so you can see this chart, which is very important, extraocular muscle. Okay, this is the superior rectus, inferior oblique, medial direction of the medial rectus, superior oblique, inferior rectus, and lateral rectus. Right? Superior oblique, intorsion. This is the inferior oblique. Okay, this one is alright. So you will probably see this extraocular eye movement in another lecture. Okay, but because it's also a part of neuroophthalmology, so I'm just going to include it here also. Alright, so the innervation of the recti and the oblique muscles, all the recti muscles are supplied by the oculomotor, except for the lateral rectus is being supplied by the 6th nerve, and the superior oblique being supplied by the 4th nerve, which is the trochlear nerve. And alright, so this is the midbrain, pons, and medulla, whereby this is the cranial, where the nuclei of the cranial nerve 3, nuclei of the cranial nerve 4, and nuclei for the cranial nerve 6. Okay, it lies 3, 4, and 6. Okay, all right. How about the eye closure and eye opening? Okay, the eye closure is of course by the 3rd nerve, and the closure is by the orbicularis oculi, by the 7th nerve. Okay, the 3rd nerve opens the eye, but the 7th nerve, the facial nerve, closes the eye. Am I correct? Think about it. Okay, now we have to go to one by one each of the cranial nerve. All right, first is the 3rd cranial nerve, which is the oculomotor nerve, which supplies a lot of muscles. Levator palpebrae muscles, which opens the eye. Okay, superior rectus, medial rectus, inferior rectus, and also inferior oblique. Okay, so if the 3rd nerve is damaged, you can imagine a lot of things here does not function. Okay, so in a complete 3rd nerve pulse paralysis, the lid will be ptosis. Okay, because the 3rd nerve function is to elevate the eye. So if the 3rd nerve function is damaged, the 7th nerve will take over. So the 7th nerve will open the eye. So if the 3rd nerve function is damaged, okay, the eyes will become closed because the 7th nerve will dominate. Okay, you understand here? I hope you understand, because it's if the third nerve wins, the seventh nerve will lose. Okay, if the seventh nerve lose, the third nerve will win. It's like that. Okay, so in a complete third nerve paralysis, there will be ptosis. The eye will be closed. Okay, and then there will be horizontal and vertical diplopia, and there will be an inability to rotate the eye inward, upward, or downward. So what will happen to the eye? The eye will, the only remaining function is the lateral rectus. Okay, so the eye will be out, and the superior oblique will pull your eye down. So that's why the eye will be down and out. Just remember that. In a third nerve palsy, the eye will be down and out. Alright? And the pupil, it depends. It can be dilated or it can be not dilated. It depends. Okay? So, alright. This is the third cranial nerve nuclei in the midbrain. So the fibers will go down and go to the anterior. It passes through the cavernous sinus. And on top of the third nerve, there is a posterior communicating artery. Okay, this posterior communicating artery can become like aneurysm. Aneurysm can develop at the posterior communicating artery. Okay, anything bulging here will directly compress the third nerve fibers. Okay, so let's see. Okay, that you can have, we divide the third nerve palsy into two, which is one is vascular third nerve, which is medical third nerve palsy, and one is surgical third nerve palsy. Okay, so medical third nerve palsy is usually because of vaso-occlusive causes. Alright, because for example, diabetic, hypertension, dyslipidemia, and it is usually pupil sparing because the pupillary fibers are not involved, and they can be accompanying headache. Okay, this headache is very it depends. Sometimes both also can have headache. So what you have to do in a medical third nerve palsy, you have to stabilize the patient's medical condition. But how are you going to distinguish whether it's medical or surgical? So the main factor is the pupillary involvement. Okay, I will explain why. Okay, this is the cranial third nerve, the oculomotor nerve, the cranial nerve, third cranial nerve. All right, as you can see, the nerve fiber is inside. All right, however, the parasympathetic fibers travels, it hitchhikes the third nerve. Okay, it travels with the third nerve to the eye in a superficial manner. Okay, so anything compressing from top, as you can see the anatomy, the posterior communicating artery is on top of the third nerve palsy. So anything pressing like a tumor or aneurysm or bleeding, subdural hematoma or extradural hematoma, compressing from top, you see the superficial fibers will be affected. So people can have surgical, we call it surgical third nerve palsy because it involves something that needs an operation. Okay, for example, aneurysm. Okay, the pupil, the main thing in surgical third nerve palsy, the pupil is involved. Okay, meaning the pupil is dilated. Okay, the pupil is dilated. Headache or non-headache, it's not a very distinguishable factor because it depends. Sometimes both have headache. Okay, all right. So this is an emergency, as patient can die if the aneurysm bursts. Okay, so if you see a third nerve palsy like this with pupillary involvement, patient definitely needs an imaging, needs an urgent CT scan. The best is urgent brain MRI. Okay, because you want to see whether is there any compression at the third nerve palsy, at the third nerve. All right, I hope you understand. The pupillary fibers runs on the outside. However, if it is medical third nerve palsy, usually the problem comes from inside. Okay, comes from inside. It's because of ischemia, because of occlusion. Okay, all right. So if you have a patient with, you suspect surgical TED, you must send the patient for, like I said before, imaging. Okay, the best imaging is MRA, magnetic resonant angiogram, which is 95% accurate if your hospital has it. Cerebral angiogram. Okay, but usually what we do in the practice is we proceed for CT scan because that's the easiest. But CT scan will definitely miss any small aneurysm, or maybe you can ask for small cut. Okay, this is a neurosurgical emergency. Okay, so however, other than aneurysm, it can also be other causes like tumor, cancer, nasopharyngeal carcinoma, trauma, brain tumor, or can also be due to inflammation of the cranial nerve, like of the meningitis, encephalitis, toxic polyneuritis, and even brain metastasis. All right. Okay. However, if the patient comes to you with like this, but the pupil is normal, you can assume that the patient is medical. It's a medical retinal palsy. Okay, patient can stabilize the BP, get the sugar control. Yes, but you still have to warn the patient that if if they have a very bad headache or the symptom worsen, it could still be surgical causes. Maybe it's like a partial third going into complete. Maybe it's actually a surgical third in evolution. Therefore, if you see a patient with retinal palsy, but the sugar is controlled, the blood pressure is controlled, then you must think of something. Okay, you tell the patient. Usually, what we do, our practice is that we will call back the patient at least in 3 days. Okay, please come back. We would like to see you again because we don't want to miss anything, because it could still be an aneurysm in evolution. Okay, all right. I hope you remember that medical and surgical technique. Okay, we will see you again in the next video. Thank you very much.